Thank you, Gary, for the very kind words. Indeed, to come back to FDA, to offer to bring the older collecting back was a challenge, psychological challenge and other. For that reason, some of the decisions, such as going to the NIH and do it with the best people so no one will have any claim about level. Just so you know, these NIH network are 4 centers chosen by the NIH from about 40 that submitted the application. So it was clear, and I'm very glad of that decision because the team also came up with a lot of things we considered, which is always very important. I'm coming from Toronto. We are unique in that we have a service called Motherisk for women who need to take medications, took cocaine, and anything of that nature, what it would do to the baby. As part of this, almost 20 years ago, we established the first and I think the only service worldwide for NVP, for morning sickness. So we have a line, a 1-809, to cover both the United States and Canada, where women can call, and that's because of the huge anxiety of women about taking medications. So a lot of what I'll show you now is because we continue to study that. So it's not just a single study. And we talked to thousands of women over the years. Some of what I'll show you come from there. So the first one is, why are women so afraid to take medications? For you, it may be a question you know the answer, but I want to go a little bit to the root of it. Well, only half of pregnancies are planned, which means women find themselves pregnant with the anxiety that they have done something they should not have done. Not so much the morning sickness, but other things. Needless to say, women need medications. And as a matter of fact, in this generation, with the age of starting a family coming up, more women need medications. In Motherisk, we see now every week women with cancer in pregnancy. Because when you are in your 30s and 40s, you will have more cancer in pregnancy. And so it goes to any direction, from rheumatoid arthritis to lupus to everything. So we see more women, more complex, which you all see in your practices. But it's more than that. Women now work in industries they were not used to work. And many industries, such as auto industry and other, are mostly women. So they come up with a question, look at our laboratories. Mostly women work with organic solvents. Question is, what it will do to my baby is very, very important. And of course, it brings all of us to the same place in history. And that's where thousands of babies were born because of thalidomide looking this way. Thalidomide was given for morning sickness. At that time, people believed, and I know some of you practiced, the drugs that circulate in mom do not go to the baby. Well, in my lab now I can measure almost anything in mom, also in the baby. For a drug not to cross, it has to be huge. Heparin, insulin, small drugs with less than 1,000 molecular weight cross the placenta. So to tell a woman, don't take a drug because it crosses, doesn't make sense. The question is, what does it do? Does it do anything wrong? So, of course, this situation that all the medical community believed that a drug does not cross led to this confidence that thalidomide will not make. And it also led to 3 years that it took to make the combination because people didn't believe that's possible. Now, when I started Motherisk, I thought I mostly will prevent malformations. But very soon I discovered that we mostly prevent termination of wanted pregnancies for wrong reasons. Every woman is surrounded by someone who tell her, stop that pregnancy because you took Valium or SSRI or something else. The vast majority of drugs we use are safe. That's the reality. But that's not what the lawyers tell the public, and unfortunately not what the journalists tell the public. So we have a very frightened public out there. Now, if 80% of women have morning sickness, many of them need medications. You cannot tell them to use crackers. Women now, 75% of American women work outside the home. You cannot tell them not to treat the condition. It will not work. So we have to be much more responsible than we used to be in the past. Meta-analysis done on all the Bendectin studies when it came to trial and all that, we were the first to publish meta-analysis. Amazing enough, at that time, 250,000 American women were reported in studies. And the meta-analysis showed odds ratios of 1, which mean exactly the same risk as the non-treated. 250,000 births. Even water was not tested in 250,000 births. And it's not likely that any time in man history we'll have a drug that will be tested more than that. That's why FDA agreed to put it as an A. Very few drugs, I'll leave it to later on, very few things have an A. A means that safety was proven. Put aside the story with the Supreme Court that threw all the evidence against, but the positive evidence, bringing everything together, showed it. And maybe the most dramatic proof is not from the meta-analysis. This is Stephen Lamb out of Washington, D.C. He found that information in administrative databases available in the United States. Here is Bendectin removed from the American market, 80, 82, 84. If really Bendectin caused malformations, they should have come down. In this particular graph, I put the limb deformities. If it caused limb deformities, as some plaintiff claims, this graph should have come down like this, as happened with thalidomide. But it does not. Look, it stays the same plateau. There are similar graphs for cardiovascular, CNS, spina bifida, you name it. This is ecological proof. You remove something from the market, if it caused the problem should disappear. So for me, this is even more strong than our own meta-analysis, because it really shows the United States as a nation and the numbers. Here is the Canadian experience. You see, here is Bendectin removed. At the time that Bendectin was removed, it was already off patent, so a relatively small company in Quebec produced it as diclectin. But of course, when the rumor came to Canada that the drug was removed from the US, you imagine what the journalists did. Except that at that time, Motherisk was already in existence, and every day of the year we empowered women, send them the meta-analysis, talking to their physicians. You see, so diclectin is used more and more, and look what happened to hospitalization rate in Canada. It comes down. This is the second part of this story. Here's Bendectin removed from the American market. Look what happened to hospitalization rate of American women for hyperemesis gravidarum. It's more than tripled. So if you do not treat a condition that needed to be treated, you're not doing any favor to women. And that's, for me, a very, very powerful graph, produced by Stephen Lamb and later on by a group of epidemiologists in Canada. That's all from public numbers. So our line answer free of charge any woman in the United States and Canada. And what we give them is evidence-based knowledge. They don't need to be treated by a specific drug because different doctors use different drugs. So which drugs are safe in pregnancy for morning sickness? There's no question that diclectin, Bendectin, dicliges, based on more than 250,000 pregnancies, is at the top, because no other drug can have so many. No aspirin, ibuprofen, penicillins. It's not those numbers. It's much, much less. So that's important. Other antihistamines, we meta-analyze them all together. So you don't need doxylamine. Other ones are also safe. However, their efficacy was not proven. No company took to do what Duchenne did, randomized trial, placebo. No company went to the FDA to ensure that it's done appropriately. Ondansetron, of course, ondansetron was invented for cancer vomiting. a very potent drug. We did the first study in Motherisk because a lot of women use it, and we did not show, based on 169 women, problems. There's a Danish study published in New England Journal of Medicine about 2 months ago, again not showing more malformations. However, it caused QT arrhythmias. As a matter of fact, FDA even outcasted the high-dose IV. Now, some of you patients need ondansetron IV because they are vomiting. So read carefully FDA instructions. Safety has not been proven. Moreover, your patient who may be dehydrated at HG may have other electrolyte imbalances, magnesium, potassium, sodium. So this question has not been yet settled. So for that reason, although we do not see more malformations with ondansetron, its IV safety for me as a pharmacologist is not proven. Metoclopramide, Maxeran. We published in New England Journal of Medicine several years ago a study from Israel. In Europe, metoclopramide is the drug of choice by many countries for morning sickness. And indeed, it was safe. Again, no one yet has done an efficacy study. None of the manufacturers of metoclopramide took it to do. So we do not know safety. And we don't know efficacy. Phenothiazines, clearly the antipsychotics are very strong antiemetics, and some of us use them in very severe cases of HG. Ginger. Ginger is used by many women. We did a study with ginger, with our callers, and there are 6 randomized trials with ginger, which I believe you will talk about. So there is some efficacy, but it's much less than diclectin, dicligis. We compare them. It's much less. And it's only the capsulated form of ginger, not the tea, not the roots. These were not better than placebo in our experiments. There's a lot of psychological morbidity which Gary mentioned. I will not go much into it. But just to give you one very sober example, in Britain, termination of pregnancy, you go to a committee. A committee in the hospital need to approve you. The public health system works that way. In Britain, termination of pregnancy because of severe morning sickness is number 2 reason. Number 2 reason. Highest reason. So severe morning sickness is the main issue, and I'll touch about it because many of our callers are from that group. And when we followed up the quality of life of these women, a lot of them considered termination. Women that called Motherisk because they could not have it. They said, we suffer so much, the way to stop it is to stop the pregnancy, which is of course terrible. And it affects very, very many aspects of family life. Of course, women who tended to terminate pregnancy, unplanned pregnancy, depression, and multiparity. And those factors need to be considered when you see a woman who has severe morning sickness. I'm telling you all that because women tell us that there is a tendency to trivialize their morning sickness. It will go away. It will go away. And as a matter of fact, it may be a good predictor of a good outcome, which is true. It is true. Let me tell you kind of 2 or 3 new things that we established through our service and clinical trial. The first is the preemptive therapy. One of my colleagues one day said, Gideon, why, before you go on a trip and you have motion sickness, you take the drug before? Why, when you go to cancer therapy, you take antiemetic before? Why won't we do it for the woman with a severe morning sickness? A lot of women call us and say, Doctor, I'm afraid to get pregnant again. Can I do something now? And you know that severe HG repeats itself in the same woman about 70%. So we embarked on a preemptive trial, mainly to give them the morning sickness drug at that time, any drug she took, because we didn't want to divvy it up. For example, it was an American-Canadian trial, and dicligis was not in America, So we didn't care if the doctor gave Maxeran or anything. And the groups were not large, but was very clear. Those who started taking antiemetics before any symptom did much better than those who started only as they would start when it kicked in. I won't show you much, but severe morning sickness decreased significantly. 18 versus 8 in the treated group, 18 in the untreated group. This was, of course, not a randomized trial because I did not control what women took. So after the publication of that paper, we just finished and published 2 months ago the prospective trial. This time it was only to diclectin, dicleges, and women were randomized either to receive diclectin before any symptom kick in or only after symptoms started. Regular, expectory way, what you do in your clinic. And again, the preemptive arm did significantly better. Women did better, and maybe the most dramatic effect, do remember, these are women, the most severe women, these women with HG in previous pregnancy. So it's not your garden variety NVP. But I think that's why the results are so dramatic. Most women who were treated as in the past had their morning sickness up to the time of delivery, so severe. Only when the placenta was delivered, it stopped. That's the severity. Whereas the group that received the preemptive, it stopped much earlier. For me, this was the most dramatic effect because we shortened this hell that are caused by them. So this is something for you to consider, especially that you have the dicleges now, that we have something to treat preemptively. This is not for your garden variety case, but that's for the woman who tell you, I had a hell in my previous pregnancy. I don't know what to do. I'm afraid to get pregnant. Well, don't wait for the symptoms. Start it before. Especially if the drug is A. It's not that those 3-4 weeks before will cause her any problem. Last but not least, I want to touch upon the acid reflux part. A lot of women with morning sickness tell us that they have acid reflux. So we say, of course, they vomit, there's intra-abdominal pressure, the hormones relax the esophagus, you expect it. But we in several studies shown that the women who have the reflux have more severe morning sickness. So it is kind of a half proof that it's the reflux that make the condition worse. So what we do now in our service, and we publish the efficacy of it, a woman that have reflux, we begin to treat the reflux too. We give them the ranitidine. Ranitidine is our first choice because it was shown to be safe for the fetus based on a large meta-analysis. The same is true for the other antacids, but with smaller numbers. So in conclusion, my personal conclusion, the return of dicleges to the American market is a huge victory because after 3 decades, American women will have a drug from the FDA to treat this common condition. Whereas before, you did not have support. You did not have regulatory support when you put something in. Second point, it's my personal request, we should not trivialize morning sickness. We have to look at the woman individually and address her needs. If it's reflux, if it's a severe case before, because women tell us that physicians don't take them seriously when it comes to morning sickness, and they feel very isolated. And our job is to ensure that their pregnancies are a happy experience. Thank you very much.